Hi everyone, thanks for tuning in to our latest edition of Phoenix Children's Live. I'm Stacy Dillier, one of the brand managers here at Phoenix Children's Hospital, and I'm joined today by Dr. Michael Shishov. He's our Division Chief of Rheumatology. Thank you for joining us this afternoon.
Thank you for having me.
Today we're talking about juvenile arthritis. So we'll just hop right in. If you have any questions along the way, please feel free to type them and we'll make sure we get them asked, okay? All right, first question. What is juvenile arthritis?
So, juvenile arthritis is a common chronic childhood form of arthritis. It occurs in about 1 in 1,000 kids worldwide. Okay. And it's the most common rheumatic illness that we see in our clinic.
Okay. And can children develop all the same types of arthritis that affect adults? Or, because usually when you think of arthritis, you think of, an adult or an elderly person who might have it, not necessarily a child.
That's a good question. So our national slogan is kids get arthritis too. So in fact, kids get all kinds of various different forms of arthritis, not just juvenile, but also lupus can feature arthritis, dermatomyositis, another illness can feature arthritis. So yes, kids can get all the same kinds of arthritis that adults do, but in a slightly different way.
Okay. And can you explain the difference between juvenile idiopathic arthritis and juvenile rheumatoid arthritis?
So there are two different terms for the same condition. That does pose some confusion. Juvenile rheumatoid arthritis is the old U.S. Nomenclature or name for this illness. It's been replaced by the international name juvenile idiopathic arthritis for several reasons. Idiopathic means unknown cause. And the other reason it's been renamed this is because we want to differentiate it from rheumatoid arthritis in adults. So by calling it juvenile rheumatoid arthritis, it makes it sound like it's the childhood version of rheumatoid arthritis, and it really isn't. It's actually different.
Okay. Okay, great. So we're trying to steer people towards the new name.
Correct.
Okay. And what are the different types of juvenile arthritis?
So as we teach the residents, there are 7 different types of juvenile idiopathic arthritis. The most common is oligoarticular, which means few joints, 4 or fewer. The second most common is polyarticular, which affects 5 or more joints. Okay. And then there is a systemic form, which features fevers and rashes. Psoriatic arthritis, which is psoriasis and arthritis. A condition called enthesitis-related arthritis, which is similar to adult ankylosing spondylitis, and undifferentiated arthritis. So it's kind of a mouthful, but those are the 7.
Okay, and is there ways different? Is there something in the gene? Is it genetic? How might someone get one over the other?
Yeah, so going back to the name, juvenile idiopathic arthritis, it's unknown cause. Okay. But we theorize that a lot of these types of autoimmune diseases are a combination of different factors, including genetics and some environmental trigger. But okay. As of right now, we don't know exactly which genes or which exact environmental trigger.
Okay, good to know. So we don't really know what causes it.
We don't, but that's not much different than rheumatoid arthritis in adults, or lupus, or multiple sclerosis, or a bunch of other diseases that remain unknown as far as their origin.
Okay, so do we know if one child has it in a family, is another child more likely to get it?
So, in fact, it depends on the type of rheumatic illness you have. So if a child has parents with lupus, they are somewhat slightly more likely to get lupus. The same does not bode true for kids. If their parent has juvenile arthritis or rheumatoid arthritis, they're not really much more likely to get juvenile idiopathic arthritis.
Okay.
So it's not obviously inherited in that way.
Okay. All right, so it's a mystery.
So it is a mystery.
How is it diagnosed? How are patients diagnosed? Do they go to their primary care provider and they're referred here? How does that process work? Yeah,
so majority of our patients with juvenile idiopathic arthritis are not sick enough where we meet them in the hospital, with one exception, systemic juvenile idiopathic arthritis, where the kids are more systemically ill and have fevers and rashes and are sometimes hospitalized for the fevers. But a majority we'll see in the clinic, and that's going to be usually based upon referral from a primary care physician. Occasionally parents will self-refer, but a majority will be referred by their primary care physician, and then we end up invariably diagnosing them in our clinic. There might be a suspicion for this condition, but usually we're the ones who make the diagnosis.
Okay. And what are some of the signs or symptoms parents should keep an eye out for, or what if they see something, should they go to their PCP?
Yeah, so I would say joint swelling is probably the most concerning feature, and chronic joint swelling. So to have the diagnosis, you have to have arthritis in one or more joints for 6 weeks or longer. And the reason for that is the first few weeks of joint swelling are usually caused by infection or reaction to an infection, and will go away. And the point is that if it doesn't go away and it's towards 6 weeks, then you're no longer looking at an infectious process. You're more likely looking at a process like this.
Okay.
But keeping in mind a very important fact also, which we teach our trainees, is that this is a diagnosis of exclusion, so excluding everything else that can cause a similar appearance. So excluding infection, excluding cancer, excluding a variety of things potentially that could mimic this presentation.
Okay, so mostly joint swelling that persists longer than 2 weeks.
Yes, I would say beyond 2 weeks, definitely beyond 4 weeks should be concerning, that even if there was an injury that preceded it or an infection that preceded things, that at that point it's gone on too long and probably a rheumatology referral would be appropriate at that point.
Okay. And can it present itself at any age? Is it after they're a year, any age?
Yeah, so the peak age, which I think surprises most people, is 1 to 3 years of age.
Wow.
So we call them the happy toddlers. And the reason we say that is the happy limping toddlers is because it's not really a painful condition. It's more of a problem of limping and swelling and stiffness. However, that being said, even though the peak age is 1 to 3, it can affect any age, less than 16 years of age.
Okay, good to know. Okay, what are the treatment options?
Okay, there are many treatment options. So the first line therapy for arthritis is to use what's called non-steroidal anti-inflammatory drugs, and the abbreviation for that is NSAID. So what we know as ibuprofen or naproxen or Aleve, an anti-inflammatory drug that can calm down the arthritis. But most kids who have juvenile idiopathic arthritis, if not all of them, will need something stronger than that. To keep it brief, if we have a patient who has very few joints, then we recommend direct steroid injection into the joint. At our hospital, we have excellent interventional radiology services where a radiologist can, using X-ray guidance, put a needle directly into the joint space while the patient is comfortable under sedation or full anesthesia. And we take out fluid, we can analyze the fluid, and we can inject steroid directly into the joint. And that can be very effective for 4 to 6 months or even longer. If that's not an option, or if it doesn't work well enough, then we have systemic therapies that can be helpful. People have probably heard about methotrexate. There's the new biologics. People might have seen the ads for Enbrel on TV.
Yes.
So those are some of the drugs that we use for these conditions.
Okay. And can children outgrow it? If they're diagnosed at 3, when they reach 19, will it have gone away? Does that happen or not at all?
So that's a very good question. And we get that question a lot in our clinic for understandable reasons. And our pat answer is no. It was old thinking that this actually is something you grew out of in puberty or adulthood. But we know for a fact there are 80 or 90-year-old grannies or grandpas that still have arthritis flares and episodes. And so we use the term either active disease or remission.
Okay.
Just like in cancer, right? It's not much different. We don't use the term that you grew out of it because the likelihood is at some point down the road you will have another flare. There are occasionally patients who fall into a category where they have one episode, we call that monophasic, and they never have another flare.
Okay.
But it's hard to define that because we would still counsel them that they need about annual visits with their specialist and that they could have a flare down the road.
Okay, so every patient is really different. It just sort of depends.
It really depends, but yeah, our pat answer is that they don't grow out of it. And another thing to point out is that once you have this diagnosis, you always carry this diagnosis. So even when you turn into an adult age, you still carry the same name, which is good because it's a better prognosis overall than having adult rheumatoid arthritis, which it's a more systemic illness in adults who get diagnosed. They have increased risk for lymphoma, for example. Kids don't have that same risk.
Oh, that's good to know. So there's that difference so positivity for if you have the juvenile arthritis diagnosis.
There is a silver lining.
Okay.
You always carry that diagnosis. You don't morph into an adult version of the disease.
Okay, that's good to know.
Yep.
Okay. How can families help their kids who have juvenile arthritis? Are there things that they can do at home?
Yeah, so obviously families are going to be the biggest advocates for their kids, and there's a lot of self-support type stuff that people can do. The most important thing is following up regularly for appointments, for testing that needs to get done, and taking the medications as recommended. Beyond that, people do ask about things like physical therapy, and we recommend that sometimes in cases where that can be helpful. Aquatic therapy, occupational therapy. Sometimes we can help out with school if that needs some intervention. And in addition, sometimes families can buy over-the-counter anti-inflammatory products like omega-3 vitamins that can be a little bit helpful. But by and large, we try to get people all the information they need at our clinic appointments.
Okay.
So we emphasize the need for following up on a regular basis.
Okay, and how often is that? Usually a year, every year, an annual checkup, or does it depend on the patient?
I would say it's a minimum of once a year.
Okay.
Up front, it's going to be more like monthly, and as things progress, and depending on the severity and the subtype of the juvenile arthritis, it could become more like every 3 to 6 months. I have some patients who are doing so well, and they stay in remission that they come once a year.
Okay. And you mentioned possible school intervention. Can you elaborate on that a little? Is there anything the school systems can do for children who have juvenile arthritis?
Yeah, so there's a couple of things. On the school side, there's a chronic health form, which every state has to provide for families, and for which we can facilitate by completing our medical part of the form, and that allows children to have a certain number of excused absences from school, and define the illness and define any accommodations that they may need in school. For example, a modified PE class, or even no PE class, depending on the condition and the severity. So that's important. And then on the family side, we can fill out Family Medical Leave Act paperwork, or FMLA, and that can have the parents have excused absences from work. And so that's an easy thing to accommodate for kids. And I mean, given that they're going to be coming for chronic appointments, that becomes a very important issue. Occasionally, if the child is doing very poorly in school, we can also have social workers from our institution help out with that as well.
Okay, and you mentioned PE. Are children able to play sports? Does it depend again on the type that they have?
Yeah, so the old prognosis for juvenile arthritis back in the 80s and 90s was not good. You saw kids come to camps in wheelchairs and crutches, and a lot of them were disabled because the drugs and therapies were just not nearly as good. The science has advanced so much that we rarely see that kind of thing anymore. And to that point, we strongly encourage continued activities in sports and PE. If they're not able to participate for whatever reason because of disability or deformity that's occurred, we still want them to participate in some way, including in physical therapy or in any kinds of activities that we can accommodate for them. But by and large, our patients have such good outcomes for juvenile arthritis that they're able to participate in competitive sports, be the captain of their football team, etc.
Okay, great. I was just going to ask, is there any sport that they need to steer clear of? But
none whatsoever.
Okay.
While they have active disease, it's probably not the best idea, especially, for example, if they have arthritis in their knees or ankles, to be bouncing on a trampoline or running, 10K races. But, once we get their disease under control, there really is no limitation.
Okay. And is there a certain joint that's affected more often than others? Like, I think of hands, but you just mentioned knees or ankles.
Yeah, I probably subconsciously said that. The number one joint in juvenile idiopathic arthritis is the knee, and the number two joint is the ankle. And after that, it's kind of a toss-up. The wrist, For polyarticular, where it's 5 or more joints, yes, very commonly the fingers can be involved.
Okay.
But that's really more on the polyarticular form of disease. But the number one subtype is oligo, or 4 or fewer joints, and that's where kids have frequently 1 knee, maybe 2 knees, maybe 2 knees, 2 ankles. Those are the most common.
Wow. Okay. Good to know. Thank you. All right. Is there any research being conducted currently here at Phoenix Children's or around the country that you know of with regard to juvenile arthritis?
Yeah, it's so funny you asked that. We just completed a meeting in our division regarding the research that we're currently conducting for juvenile arthritis. It's called PRCOIN. It stands for Pediatric Rheumatology Care and Outcome Improvement Network. I'm glad I got that all out. And it's a nationwide quality improvement project. The host site is Cincinnati Children's Hospital Medical Center, and then we're one of about 20 participating centers. However, just to toot our own horn, we're the only center in the Southwest that participates in this consortium. It regards improving outcomes and quality improvement in children with juvenile idiopathic arthritis. So we've been doing this for about 2 years now.
Okay.
And we are making leaps and bounds in terms of how many patients we have registered and screened, and the information that we're collecting is getting to be more and more clinically meaningful, and we're seeing better outcomes in our patients.
That's great. Is it an ongoing consortium? Is there a stop date in 2020, or is it just going to continue so we can continue to do research and help patients?
Yeah, so in fact, this particular registry or quality improvement project does not have a stop date.
Okay.
So there's no drug intervention, where if there were a drug intervention and sponsored by a pharmaceutical company, then it would have a stop date. But this is not like that. It's quality improvement, or QI.
Okay.
And so the idea that it goes on ad infinitum, and that by doing this kind of work and focusing on quality improvement, you're actually improving outcomes in your patients just by being in collecting information and being in this project. There are 2 meetings a year that we go to in Cincinnati, where we learn a whole lot of things, and then we bring back the education and the momentum and the motivation from those meetings back to our site. And the goal is to have everybody in our division, so all of our doctors, our nurses, our staff, participating in this project. It's not just a provider project.
That's great, and another reason for patients to come to Phoenix Children's, right?
Thank you. Yes, yes, indeed.
And that gets us right into our next question. Tell us about the Division of Rheumatology here at Phoenix Children's.
So we've been around for 11 years. I got here 11 years ago when there wasn't a program at that time, and that was part of the motivation to come here, was to start a program for pediatric rheumatology for a state the size of Arizona. It was almost inconceivable that there was no pediatric rheumatologist. The adult rheumatologists were taking care of the kids at that time and doing the best they could. But they were actually part of the recruitment process, believe it or not, in combination with Phoenix Children's. And I've been fortunate enough to be able to recruit 2 additional rheumatologists. We actually just added on a 4th rheumatologist, so we have 4 rheumatologists. We are the only rheumatologists in the state of Arizona, and we get referrals from not only all over the state, but also surrounding states like New Mexico and Texas and Colorado.
That's great. Is our program multidisciplinary? Do we involve, I know earlier you mentioned interventional radiology. What other areas of the hospital do we work with? What are some of the sticking points for our division?
So I would say our main emphasis is providing outpatient care for our patients. We have patients with chronic illnesses. Our goal is to keep them out of the hospital, to keep them at home and at school. Obviously, sometimes our patients do get hospitalized. Sometimes we meet them for the first time when they're in the hospital without a diagnosis. So we provide inpatient care for Phoenix Children's, obviously the outpatient care. And yes, our field crosses multiple other specialties. we coordinate care with the radiologists for the joint injections, as well as with the radiologist team for all kinds of imaging that we might need, like ultrasound or MRI or X-ray. We obviously get referrals and collaborate with orthopedics because there's some similarities there in terms of their handling of different bony problems and sports medicine issues. And dermatology, some of our patients get really unusual rashes, so we rely on them to help us make diagnoses and provide skin biopsies and those kinds of things. We do infusions all over campus for our patients. So infusions are drugs like biologic therapies that our patients might need for various different conditions, and we provide that service. We do joint injections in our office as well for some of the older kids that can sit still and tolerate it. So those are some of the things that we offer.
Okay, great. And what's the difference? You mentioned earlier when you were talking about creating the clinic that there was only adult rheumatologists. What does it mean to have a pediatric rheumatologist treat a child versus an adult rheumatologist?
So one of the basic differences is that a pediatric rheumatologist performs a residency in pediatrics as part of their training and then pediatric fellowship each 3 years, versus an adult rheumatologist has performed internal medicine training for 3 years and then adult rheumatology fellowship for 2 years. It's entirely possible that the most exposure they've had to kids in their training might be about a month during their adult rheumatology fellowship, where they hung out in a pediatric rheumatology clinic. And so that might be okay if the child is, I'm just going to make this up, above 12 years of age, right, where they're going to be cooperative and answer questions and so on and so forth. But for a child that's like a toddler, which is the peak age of juvenile arthritis, let's say a 2-year-old, who's very fearful and very difficult to examine, if I'm that adult specialist, I'm going to feel very awkward and even fearful and anxious about making that kind of examination. So it really takes kind of a special adult rheumatology specialist to get that experience and get that confidence. And at the end of the day, also, keeping up with the literature. It's not the same to say that you're up to date on adult rheumatology literature in your field, that you're also up to date on the pediatric literature. I don't find it conceivable almost you'd be able to do all of it, to stay up to date on everything. So the idea is that we are subspecialized for a reason, and I don't keep up to date on some of the adult rheumatology literature because it's not pertinent to what I do. And there's just so much information out there. And so I think those are some of the obvious differences. But I would say that the adult rheumatologists that we're seeing the kids here did a fabulous job before I got here, the best job they possibly could. But I think they're also very grateful that we have these services now and they don't have to take care of that population.
Definitely. I imagine it's completely different caring for a child than it is for an adult.
Just like I wouldn't want to see an 80-year-old with chest pain. I'm just not trained to do that.
That's great. All right. Are there any other additional resources families can turn to?
Yes. So we are proud to say that the Arthritis Foundation, which I think people know about, their pediatric program in this area, this neck of the woods in Phoenix, is one of the strongest in the country. And so since I got here, I haven't had to do much in terms of building that program. It was kind of there already, and they just kind of fit us in. So I would say the easy answer is that anybody diagnosed not only with juvenile idiopathic arthritis, but lupus or any other childhood rheumatic illness, that would be the easy resource for them, is to get in contact with the Arthritis Foundation Phoenix chapter. And a couple things. We provide through the Arthritis Foundation 2 camps a year. So there's a summer camp in early June in Mayer, Arizona, which is close to Prescott, and that's for kids with any form of a childhood rheumatic illness. It's for the kids only, and sleepaway for about 5 nights, and then in September, I believe, there is a family camp where the families, the entire family, including unaffected siblings, the parents, get to go to the camp for a few nights. And that's all covered by the Arthritis Foundation and people who are very generously contributing monies through philanthropy So the families have to pay a very nominal, like a small nominal fee to send their kids to these programs. And so a lot of our kids obviously attend these things, our patients, and it's been very nice to be able to offer that.
That's great. The family one goes back to one of our sticking points at Phoenix Children's is the family-centered approach and the family-centered care. So that's really neat that they offer a camp for everyone.
It sure is.
Okay, if kids need to be seen by a rheumatologist, should they go to their PCP first? How can patients get to our Division of Rheumatology? What is their best route?
Well, so I think the best route is going to be through their primary care physician. But we don't mandate that you have to get referred. So if you want to self-refer because your doctor isn't listening to you or referring you, or for whatever reason, maybe you don't have a doctor, we don't block any referrals coming in. We want to see you. But yes, the easiest avenue, and I would advocate that you have a pediatrician as your primary care physician, is going to be through that doctor.
Okay, great. Is there anything we didn't touch on that you want to get out there?
Yeah, I would say one more thing is I think the general thinking is that specialists especially have long waiting lists to get in. We don't have that kind of issue because, as I mentioned previously, we have 4 providers seeing patients, even though we're covering the entire state. We have a couple of things worth mentioning. One is we have same-day new appointments available through your pediatrician or your family doctor. We can get them in the same day or the following day. Our wait times for new patients are typically less than a week.
Wow.
And our wait times for follow-ups are not much longer than that. So finally, we not only see patients out of our Thomas campus here at the Children's Hospital, but also in the surrounding areas like in the East Valley and in Avondale.
Okay, great. And we can post all that information for viewers so they can know where to find you.
Great.
Perfect. Thank you very much for joining us today.
Thank you for having me.
It was great having you. If anyone has any questions later on, please feel free to post them, and we'll make sure Dr. Shishop gets them. And be sure to tune in on Tuesday, May 16th for our next Phoenix Children's Live.